Супер. Всем привет, добро пожаловать на MEDTalks. У нас сегодня он в таком официальном достаточно формате, непривычном. I will translate a bit later, and just a few words to start. Вот. Проходит достаточно необычном таком официальном формате в рамках открытия точки кипения. Мы подумали, что было бы здорово порадовать нас и вас, да, такой темой, как гинекология. Вот. И сразу скажу, что я перейду сейчас на английский язык, и у нас будет презентация на английском языке, говорить мы будем стараться тоже на английском языке, но если что, вы и я можем немножко переходить на русский, прям совсем чуть-чуть, если нужно какое-то там слово объяснить или что-то непонятно, не стесняйтесь задавать вопросы. Вот. Для тех, кто меня не знает, меня зовут Лиза, я руководитель Международного комитета по необменным комитетам. Вот, у меня сегодня чудесные спикеры Марина и Юля. Вот, и прелесть в том, что вы тоже можете стать спикером в следующий раз, если изъявится желание. Вот. Давайте тогда перейдем к презентации.
Okay, I'm switching to English. Raise your hands. Put them down. Okay, cool. Now, repeat. Do it together with me. 1, 2, 3, 4, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 1, 2, 1, 2, 1, 2. 1, 1, 1, 1.
Can we continue?
Можно продолжать?
Можем продолжать?
Да.
Супер. Sorry, sometimes I just forget to switch languages. Yeah, urinary tract infections. I think that pretty everybody during their lifetime struggle with this type of infection. This is a very common infection, and that's why we chose to discuss this. Sorry. And just an overview of urinary tract. We have usually urinary tract is differentiated between lower tract and upper tract, and lower tract consists of urethra and bladder, urine bladder, and obviously infections of lower tract are urethritis and cystitis. Sorry, it's very challenging to pronounce all of that, but I will try my best. And upper tract consists of ureter and kidney, and upper tract infection is obviously pyelonephritis. Tanya, did I?
Correct.
Acceptable. Okay. Acceptable. Pyelonephritis. Yeah. So you can see all the organs we need to know. Or uterus in a woman, actually. Uterus, bladder, sphincter, urethra, ureter, and kidney. So I think we can go to the next slide. And what is the mechanism of urinary tract infection? It's actually the bacteria ascending from the colonized urethra into the bladder and then into the kidneys. Ascend, so basically it just goes up, yeah? Descend, goes down. And sometimes it's like very rare, casuistically rare. It can be descending, so goes down from the bloodstream, but it's like very rare. So types of pathogens are like mostly the type of pathogen is Escherichia coli. 50% of all the urinary tract infection causes. And risk factors of UTI. Actually, like there are main factors and there are additional factors, but I personally think that additional factors are more common than main factors. But we will go through all of them. So basically, main factor for UTI, wherever it's infection of lower tract or upper tract, is previous UTI. Like, if you had UTI once in your lifetime, sorry, it's a risk factor that you will have one later. And as a child or as a grown up, as a teenager, maternal history of UTI. So if your mom had an UTI or frequently had UTI infections, it's more commonly that you will have one. And women professions in which frequent I mean a lot of urination, so you have a possibility to go to toilet properly. Frequent urination will not be possible as military nurses, teachers. Incomplete bladder emptying, you have some troubles with emptying of the bladder. Urinary incontinence, and this one may be tricky. In Russian it's недержание. Okay? And rectocele, cystocele, urethrocoele. So basically, there is a connection between one organ and rectum, for example, and another one, urethra, and urinary tract calculi. But I will specifically tell you about additional factors, and in my personal opinion, anatomic. They are not abnormalities. They are not. Just anatomy of women's reproductive system itself is a risk factor, because in women, urethra is anatomically very, very close to the anus. So yeah, it's a risk for UTI. Also, a lot of women struggle from wide and hypermobile urethra, and this is also the risk factor for UTI. And especially if you a woman who is practicing anal sex or anal intercourse. It's very serious for you. It's really important for you to take it seriously and be as safe as possible, because it can cause UTI. Also, frequent or recent sexual activity. Don't don't forget to use toilet after your sexual activity. Yeah, it's not a myth. It's a rule that can save lives. Also, diaphragm contraceptive use. Use of vaginal spermicidal agents. Vaginal atrophy is very rare, actually. Obesity, which is not rare at all. So obesity and diabetes are also risk factors for UTI. And sickle cell trait disease is also very rare, especially in our region. In in Mediterranean area, maybe it will be a risk factor, but not in our case. So, and also I can say that a lot of women who changed their country recently, they immigrated or something else, they also struggle from UTIs. And the reason, I don't understand the exact reason, but maybe it's connected to the water the woman consumes. So, yeah, women's body is a miracle. So let's talk specifically about cystitis, pyelonephritis, diagnosis and management. And also about asymptomatic bacteriuria, and I prepared a little question for you, so don't be afraid to answer, even in Russian, it's okay, but preferably English. So we will start with cystitis, and it's the most common actually type of UTI affecting women, and involves only the urinary bladder and urethra, and the symptoms are dysuria or painful urination with the urinary frequency, meaning fast, not fast, but very often urination, and urgency. So it's like I need to go to the toilet. This is the synonym for urgency. Hematuria, but not always, and it's also very rare. No fever. This is really important. Fever is the only, not the only, but the clinical symptom you can distinguish cystitis from pyelonephritis, because cystitis doesn't have fever usually, and no costovertebral angle tenderness. Can someone be a volunteer for me? Yeah? Okay, come to me. I will show you what is costovertebral angle tenderness, actually. So basically, yeah, back to the people. So basically, you have a spine here. You have costovertebral angle, which is right here. And with a person with cystitis or pyelonephritis, usually if you palpate here, you will have the patient will be, oh my god, it's so painful. So this is no, don't pretend. So this is basically costovertebral angle tenderness right here. And what is flank pain? How do you think? What is flank pain? Where it's located? Flank pain.
Pain lateral.
Sorry?
Lateral side. I think that it is a pain in lateral side of the abdomen, probably.
No. Other gases. No, it's actually what we call flank pain is right here. So basically, if the person is like that, oh my god, this is so painful, this is a problem. Thank you very much. And we will see a picture right here. So we have bacteria, usually like 50%. It's Escherichia coli coming from the rectum. You see, this is, I hope how Shriha Koli sounds like, and it goes to the urethra and to the bladder, and emptying the bladder flushes out bacteria. That's why I tell you, girls, go to the toilet after the sexual intercourse. Yeah, it's really helpful. And here, like, this is bladder and urethra free of bacteria. Any questions so far? No? Not yet. Okay, this is great. So to the types, they are just two types, and they are pretty simple. It's uncomplicated and complicated, and this is how inflamed bladder looks like. Not very well, actually. Yeah. So man bladder. Yeah. Yeah, I think it's a main bladder. Yeah, it's a main bladder. But we are talking about both genders, actually. Uncomplicated. Uncomplicated cystitis occurs in a woman who is not pregnant, has not had any recent treatment with antibiotics, has not had another UTI in the last 6 months, or 2 UTIs in the last 12 months, and has no decreased immunity due to other conditions. Which conditions this could be? Conditions that decrease immunity. What?
HIV, diabetes.
HIV, diabetes, yeah, any immunosuppression from maybe cancer treatment, and has no signs of upper tract infection. And as I already said, which is the first sign that you may probably have upper tract infection? Which sign? Fever. Yeah, right. Fever is the first sign you may probably have upper tract infection. I'm talking about upper tract infection. Upper tract infection is pyelonephritis, and caused by infection from the bladder when it ascends to the kidneys. Yeah, so also goes up. Involves one or both kidneys, but actually both kidneys is very, very severe. Like, we don't want this to happen in any case, and rarely upper tract infection will arrive by descending from the bloodstream, but as I already said it casuistically. Untreated pyelonephritis may lead to kidney damage, including secondary hypertension and renal failure. What is renal failure in Russian?
Which недостаточно?
Yeah, right. And sepsis and death. Not very happy. Yeah. So symptoms of upper tract infection are fever, chills, back pain, also post-vertebral angle tenderness, flank pain, and urine has a lot of leukocytes. Women will have symptoms of the this. Sorry, I just this terrible disease. Some patients experience nausea, vomiting, and diarrhea. And my tricky question. We'll talk about asymptomatic bacteriuria. So basically, it's when you find bacteria, but women or men actually don't have any symptoms at all. So does not cause any symptoms, can be identified only through coincidental. What is coincidental? Случайный. Coincidental urine analysis shows bacteria in the urine, and treatment is not usually, this is a caps lock, yeah, it's usually not needed, and treatment of asymptomatic bacteriuria without this the only one indication, may cause harm by damaging microbiota of a woman or man. So there are 3 types of urine analysis: complete, with performed in a lab, with a microscope, and rapid is the most common one with a doctor in a doctor's office with a test stick, and also 24-hour urine collection, which is very popular in Russian med books, but actually it's not very useful, and it's not very frequently used. So, my question for you: what is this miracle, the only indication to treat bacteriuria? What it can be? What can be the only indication the doctor can treat a woman or man? No, a woman in that case. The only reason. What is the only reason? I will ask you.
Pregnancy.
Yeah, yeah, it is pregnancy. Who said that? Oh, nice, Dmitry. Dmitry is a very frequent MEDTalks visitor, so yeah, it is pregnancy. But I will also ask you why. Okay, we will see the progesterone functions, but I will ask you which connection we have from progesterone functions to treating upper tract. Sorry. What reason? What is the connection between asymptomatic bacteriuria and progesterone? But for the start, I will tell you what common functions of progesterone are. It regulates the mood, it helps the growth of the nervous system, and may prevent epileptic activity in the brain, and also, very important, it acts as a sedative, not only for sleep, but for all internal systems of the body. So, if someone can lead us from asymptomatic bacteriuria to pregnancy, and from pregnancy to progesterone and treating this bacteriuria, I will be very happy. So, how do you think? Why high level of progesterone can be very dangerous for women with asymptomatic bacteriuria? Did I finally get my question right?
The immune system.
Not exactly. I can tell you, but I also wanted you to maybe guess, maybe try to.
Maybe it's toxic.
Progesterone? No.
The high levels.
Not exactly. No. But
Это фактор роста бактерий, что такое?
no, it's not. It's also not a factor, a risk factor. But okay, progesterone has a very nice for pregnancy effect of relaxing everything, and also by that I mean progesterone will relax muscles in the bladder. It relaxes sphincter between bladder and ureter. So high level of progesterone will usually cause risk of reflux from ureter to bladder. Yeah, this is right. Okay, but reflux is fine. But if a woman has asymptomatic bacteriuria, these bacteria will come to the bladder and cause, firstly, lower tract infection, and secondly, upper tract infection. So it's necessary, it's just like a rule, to test every woman for asymptomatic bacteriuria between 12th and 16th week. And if we find that the woman is suffering from asymptomatic bacteriuria, we treat her with antibiotics, preferably amoxicillin, nitrofurantoin, or any kind of test. So why this condition is so dangerous to a mother and to the child? So asymptomatic bacteriuria in women cause increased risk of maternal pyelonephritis to the level of 30%. It's incredible amount of possibility. So we don't want that. We don't want pregnant women to suffer from pyelonephritis. And what are the complications? Premature birth, which is преждевременные роды, septic shock, in up to 20% possible septic shock for both women and newborn, RDS, which stands for acute respiratory distress syndrome, and you can see here that all the alveoli, this is the picture of normal alveoli, and this is the picture with alveoli filled with fluid and block gas exchange, so it's very dangerous. It can cause newborn death, and also other kinds of non-cardiac pulmonary edema.
What?
Sorry? Anybody said? Somebody said? Ask something, or okay, we can continue? Okay. So we are getting close to the diagnosis and treatment. Diagnosis we have already discussed, that is urine dipstick, performing the test in a lab with the microscope, urine culture with sensitivities to antibiotics, and this will provide appropriate treatment. So we can choose appropriate antibiotic for that. And the most important references are white cells and blood cells to differentiate with which condition we can differentiate pyelonephritis if we see blood cells. You know, other. What other condition can have red cells in the blood?
Glomerulonephritis.
Yeah, glomerulonephritis is actually the correct answer. Yeah, so we should differentiate pyelonephritis with glomerulonephritis at that step. So, and also instrumental testing, ultrasound investigation, and cystoscopy. This is the picture of this dipstick. I don't know if it's common in Russian hospitals. Is it common? No, it's not. But it's actually a very cheap and very efficient way to test urine. And also cystoscopy. There is a cystoscope, and this is a doctor, and this is a monitor. And with cystoscope, the doctor fills bladder with water and see what is going on there. All right, and treatment is very not very simple, but very straightforward. We have bacteria, we need to treat with antibiotics. So can you just not talk while because it's very disturbing. It's okay. And prevention, wiping from front to back. Simple but very effective, yeah. Like in newborns, we have, as a pediatrician, we have a rule that we don't wipe female babies back to front, because it can guide bacteria from anus to urethra. And the same rule for grown-up, actually. Don't wipe back to front, only wipe front to back. Avoid delayed urination, drink more, and also don't forget to go to the bathroom after sexual intercourse. Actually, that's all. We don't have time, unfortunately, today for this case, but we will have another very interesting case. And now I would like you to maybe to ask some questions if you have. And next topic will be endometriosis, and Yulia, our beautiful speaker, will tell you everything about endometriosis. Any questions? No? No? Okay. Everything is perfectly clear. Hello everyone, my name is Julia and I'm here to talk about endometriosis. So let's begin. First of all, we need to find a definition, what exactly endometriosis is.
Очень погромче, там ничего не слышно.
Okay. In order to give a definition to endometriosis, we need to know what endometrium is. So, it's the inner mucous membrane of the uterus. And it is located in the cavity of uterus and only there. So you can see there's 1 to 3, yes.
Yeah, this inner layer is actually what we are looking for.
Yes, and that's only where it should be. And the answer is endometriosis is when it's a chronic disease marked by the presence of endometrial tissue outside the endometrial cavity. So when this tissue is located where it should be normally. And do you have any ideas which spots can be covered?
Cervical canal.
Cervical
Cervical canal.
Yes.
Cervical
What else?
Cavity.
Anything.
Anything.
Particularly, yes. It can be gynecological problems, and also it can be different, like from intestines and lungs to anything, to scars,
Eyes, yeah. There is a horrible picture of, it's very rare, but it can be in the eye, actually, endometrium tissue. So, to the spots?
Yes, and it depends on the spot. The symptoms depends on the location of this wrong tissue, which is placed where it shouldn't be. So, but most common sites are ovaries, fallopian tubes, and ligaments. This is what is the
So let's see our pictures. Yeah, I think we can move it. Yeah, everything is clear. Excellent. So large intestine, which is post-kisheshe. This is a fallopian tube. This is uterus, right ovary, and you see this kind of like a blood spots over here, blood spots here and here and here. Yes? Yes? Okay. So this is basically endometriosis. This is more visually clear, like they're bigger than previous picture is, but also fallopian tube, uterus. Sorry, I don't have. Thank you very much. Uterus, fallopian tube, and endometrial spots.
and also over.
Yeah.
It's actually a rule to use not a
Finger.
but and our Igor Valerievich is very strict about. So here we can see the spots over here and over there, and I guess we can do it.
Okay.
There are 5 main theories of endometriosis. It's retrograde menstruation, when it goes the wrong direction, so after. Immune system dysfunction, metaplastic theory, benign metastatic theory, and stem cell theory.
Extrauterine, yeah.
Yes.
Mm.
Okay.
Yeah, yeah. And this is basically retrograde bleeding. It's like, I think we can compare to reflux,
Yes.
like a reflux. But this,
But not up,
just like that. Yeah, a bit up actually. Yeah. So next slide.
yes. Risk factors are the following: is family history of endometriosis, it's never carrying out any pregnancy, and early menarche, late menopause. And I can say that nowadays the age of this disease, it goes lower, so even teens can be diagnosed with endometriosis, and it wasn't like this 2 decades ago. It just goes up and up, the risk or the frequency of it.
Can I ask a question?
Sure.
How do you think there is a following risk factor, never carrying any pregnancy? How do you think, what is the connection between never being pregnant and endometriosis? Hmm?
Frequently exchanging of. Можно вас?
Yeah,
Эндометриоз, он постоянно обновляется, потому что менструальный цикл каждый месяц
Ага.
происходит, и во время беременности менструальный, эндометрий на месте, и вот это постоянное обновление, вот очаги распространения.
Perfect. Excellent. Actually, yes. The main reason that causes this connection between never being pregnant and endometriosis is estrogen and ovulation. So when you are ovulating, when you are menstruating, you constantly change your endometrium, and if you are pregnant and also a few months later when you are breastfeeding, you don't have menstruation, you don't have ovulation, this is blocked. So actually this is how nature works against us women. Yeah. So this, it's not actually a myth that you should get pregnant, that everybody get assumed by these old doctors, old gynecologists who says that you should get pregnant. Actually, there is a connection between women's health and getting pregnant. Yeah. And never being pregnant means that you had lots of menstruation and lots of ovulation, and you constantly changed your endometrium. So
your organs, they don't have any time to rest.
yeah, don't have any time to rest. Next one.
As if pregnancy is such a rest.
Yeah, not exactly, but hello.
Hello.
You can join us if you want.
I'd like to join you, but I have to turn off my clothes.
To what?
To снять мою одежду верхнюю.
You can снять твою одежду верхнюю.
It's really, really hot here.
Okay,
Your accent is really, really Russian.
А, ты тут!
Okay, so sorry, Julia, go on.
So these parts of tissue where it's located, when it's located where it's not supposed to be, it calls endometriosis implants. They are benign, and they have same estrogen receptors, same proliferation, secretion, and menstruation cycles. These places, these sites, but they have 2 key differences to normal tissue located in the cavity of uterus. It's high levels of enzyme aromatase, which causes production of estrogen, and pro-inflammatory factors, causes inflammatory and scarring. So actually high level of estrogen is also kind of a reason of endometriosis to happen, and the treatment is based on getting it lower and progesterone up. So any imbalance between estrogen and progesterone can worsen, symptoms of endometriosis. Okay. There
We're
is
supposed to put some yes.
frozen pelvis. What is frozen pelvis?
It's scars.
Yeah, it's a scar tissue. So basically, you can see like ice flakes here. This, sorry, I'm a very simple girl. I don't use this. So basically, this area, which is like covered in ice, is as Julia.
Scars.
Yeah, scar tissue, fibrotic.
This is what causes pain. It's like very. It's not from the beginning. It's look like this. But it can be. It can be.
No, it's not. It's not from the beginning. It's like a long-lasting process that caused this kind of picture.
Yes, but scars also can be the beginning of endometriosis. Endometriosis can grow on scars, and it's seldom, but it still can happen. And so forth. Changes in hormone levels and chronic inflammatory causes bleeding. So menses can be irregular, they can be plentiful, they can be scarce, and it also you can also have a patient can have some
no, it's not.
Expressions after a period. So
It's
3
actually-
days.
It's actually not like that, but
3 days after, normally everything just goes away, and here we go again, but it's not menstruation. Next.
so
Go back.
back.
We can ask a question
Ah,
here. So maybe you know what is so sweet about endometriosis? Have any ideas? Have you ever faced with any topics or any words, sweet words?
connected to endometriosis, which it's a metaphor actually. It's not like everybody is so scared, like nothing sweet happening here.
Sweet in the meaning of nice or sweet in the meaning of sugary?
Sweet in the meaning of sugary. Yeah, it's like a dessert.
Something that it looks like something sweet.
I have an idea. When we do laparoscopy, we can see endometriosis often looks like a cherry, a fruit.
Or
probably.
like
also
that.
a fruit, but someone said chocolate chip.
Chocolate chip.
That's exactly what I meant.
Look at that.
Yes, it looks like it because it's the old blood, and the color is brown, so it can also look like chocolate. That's why it's called chocolate science.
Oh my God, what happened? Sorry. Oh, it's unpredictable.
Who's so hot? I wonder because it's like super cold.
How does that? Okay, so sweet, yeah.
So contain the old dark blood and shed tissue, and that's why it looks like they get too large, and when they rupture, they cause a strong pain, and they look like this. And we can diagnose this with ultrasound of the pelvic organs, MRI, and laparoscopy. So this is laparoscopy in the picture. The symptoms are related to locations. As I already said, there are different locations, and you all know it. So let's see, reproductive organs.
Let's ask. How do they think? Which unusual symptoms a woman with endometriosis could suffer from? Not only the pain, just casual pain,
Yes.
but also what kind of pain it could be. Are you going to be a gynecologist?
No, I'm not.
You're not?
Pediatrician.
Pediatrician.
That one woman has bleeding from her eyes.
Yes.
And another woman had how many? I have no idea how it is.
Yeah, bleeding from the throat,
Throat, yes.
coughing with the blood, yeah.
Because both of them has an endometriosis. The first one had endometriosis of her eyes, another one had endometriosis of her lungs.
Yeah, yeah. Yeah, and you can have, not you, but people can have, patient could have endometriosis even in the lung tissue, and that's really terrible.
It's super rare, and it's how to say casuistic.
Yeah, but what do we mean by reproductive organs? We mean ovaries,
And uterus.
ovaries, uterus, fallopian tubes, ligaments, also in the reproductive area. So
it's pelvic pain, bleeding, dysmenorrhea, it's painful menstruation, and dyspareunia, painful sexual intercourse.
it's not. This is for you boys. It's not all right when your girl says, yeah, it's painful. It's painful. It's not all right. It shouldn't be like that. Like even if you're a sex giant, yeah. No, it shouldn't be painful at all. So this is the sign that something is wrong inside the reproductive area.
Not necessarily the reproductive area.
Not.
That it is definitely a question to raise.
Sorry?
It's definitely a question to talk about and to think about.
Yeah. So just a warning sign for you. Yeah, it's not.
Go to a doctor.
Yeah, it's can be connected with I think nervous system and also gastrointestinal intestinal system. Yeah. So next slide.
Yes. Founder Douglas is dysgesia, pain during defecation.
Yeah. So do you remember what is pouch of Douglas? Yes. Yeah, so basically, yeah, right. It's a cavity between uterus and rectum, and we have another cavity, which is between urine bladder and uterus. Yeah.
The bladder, if it is in the bladder, it's urgent, frequent, and sometimes painful urination. So we need to
Differentiate.
differentiate it with
Lower tract, lower tract infection.
the intestine, it's abdominal pain.
Mm-hmm. What are you doing? Why? Okay. Sorry, guys. Usually. Okay. We're close. Yeah, I think we're here. Diagnostic.
And also, I would like to say about other symptoms I've read about recently. It can be pain in the legs.
Pain in the legs?
Yes.
Really?
Symptoms. And in the back, which is neurological part, but it also can take place when a woman suffers from endometriosis. So it's very rare, but can.
So also I think there is like a perfect laparoscopic picture here. Like you can see, this is a sigmoid bowel, this is uterus, this is endometrioma. Look how huge it is. Obviously, it will be painful for a woman because it's like it's pretty the size of a uterus. See, this is an endometrioma, and outside there is a scar tissue. Inside there is blood and all these blood clots. Anything to add? You want to add here? No?
Also this. Yeah. Also this spots Like we've seen it before, and also these places or sites of endometriosis.
I think that this is the ultrasound picture of the same patient. You see, there. No, it's not. It's also endometrioma, but it's located nearby the left ovary, and this is nearby the uterus.
So now we talk about treatment, and as for diagnosis, I guess we skipped it. As for diagnosis, it's laparoscopic, but it's just in the not from the beginning. First of all, there are symptoms, and then ultrasound, MRI can show us very clear, but actually ultrasound cannot show us pictures of endometriosis sites. It can show sites.
Yeah, actually, like you're talking about, like we can differentiate endometriosis spots during the ultrasound. Only something that is very large,
Like sites.
size, yeah. So basically, if the condition is very severe and we have endometrioma, we can see endometriosis and we can say, okay, this patient has endometriosis by performing ultrasound. But if the picture is like that, with only the spots, you can't say anything via ultrasound.
Yes, you can. So three main purposes in the treatment. It's managing pain because sometimes it's so severe, and it's the main reason women go to the doctor because otherwise, well, I'm just fine. And when it's severe pain in the bowel, in the back, in the abdominal pain or pelvis pain. It makes her go to the doctor, and it's the first thing need to be treated. Limited progression of implants, so we need to stop this tissue from going other place where it should be. Addressing subfertility.
Meaning treating.
Meaning treating, yes. So sometimes it's also a symptom when a woman cannot have a baby.
They are trying to conceive.
Yes, but they a year or two passed and nothing. So it's also a reason why they visit doctor. The treatment, medical treatment, not surgical, is estrogen, progesterone, oral contraceptive pills, very common. It's a variant suppression which reduces pain. But the problem is that they need to be taken for a very long time, like 6 months or more, and when a person stops doing it, it can come back again. So it's not the first one that prescribed. The first one is progesterone analogs. For example, the Frila is Dienagest.
Yeah, very common in Russia, I think.
Also, Vizara, it's absolutely the same, Vizana, but the consisting part is Dienagest. It inhibits growth of endometrium.
I've been prescribed Visana. I have endometriosis and I'm taking Visana as a treatment for endometriosis. Yeah, so it's very common, guys.
It works like it has affinity to progesterone receptors, and it connects to these receptors, and estrogen level goes down, progesterone goes up, and this size of endometriosis, they go shorter, smaller, and boom, disappear. Also donazole steroid and gonadotropin releasing hormone modulation, but they like second line. Second line, yes. The first one is progesterone analogs and estrogen progesterone contraceptive.
Vizana is where Diana guessed and Vizana, I think.
Vizana and the Frila is the same, but Diana guess is what they consist from. But the Frila is basically just the children.
So if a woman
Wants to have a child, yes, then it's excision of endometriosis implants. And it's important to excise them, to remove them, not to like reject,
not to coagulate.
to coagulate and burn, because it's better to remove this spots, and it actually increases the condition of woman immediately. When completed childbearing or if pain is debilitating, what is debilitating? Something more. It's not something connected with the brain. Not really.
Very strong, yes.
So strong, severe, unbearable, intolerable. It's all the same. It's like cannot bear this pain. It's hysterectomy and oophorectomy with excision of other endometrial implants. So when enough children, then hysterectomy. When wants to have a child, then this. But still, first need to be treated without surgical intercourse. It needs to be treated with medicine, with pills, yes. And only when it just doesn't work at all, need to be procedure need to be done.
Actually, I think that drug treatment, it doesn't cure, it's not radical, you know. It just make women's life better, and that's all. It doesn't treat like completely. So the only way to completely be treated from endometriosis is hysterectomy, which is a very sad option.
Very severe.
Yeah, and has a lot of complications itself.
It's a big invasion, so it needs to be discussed with other doctors and surgeons and gynecologists in order to decide whether it's needed to be done or not. Thank you very much for your attention.
And also we have our secret case report. Yeah, maybe some questions. Sorry, I'm very nervous today.
Okay, it's fine.
So, any questions about endometriosis? Even silly ones. Silly ones are the best ones, I think, because we can answer them.
Definitely. Yes. I feel we need an energizer.
Okay, I'm just not fond of energizers, but
Of course you are, but I am.
you can, if you,
I can, if you allow me.
of course.
Oh, thank you so much.
We have a.
Did you need me? Get up. Now the shameful ones. Oh, okay, actually I have the one that is really, really suitable to the situation and to the topic you're talking about. Okay, look at me and first look and then repeat. Bananas of the world, unite. Again, bananas of the world, unite. Now, peel, banana, peel, peel, banana, peel, banana, peel, peel, banana. What next? I don't remember. Okay, cut, banana, cut, banana, cut, banana, cut, banana, smash, banana, smash, banana, smash. Just thank you very much. There is the next step, but I won't get it. Get predict.
Давайте возьмите. Давайте. Конечно. Ставьте на таблицу.
So are you ready? Are you ready to start? I have for you a case report, but it won't be a dialogue presentation because I will give you you some information about the patient, about the case. And I want you to ask me questions about this patient. I will give you some chief complaints. I will give you information about physical examination. But I want you to ask me questions. It's okay if you ask them in Russian, but I will only, unfortunately, answer in English. So please get ready to that. And I hope we can together solve this case. So let's get started. So you're a gynecologist or surgeon or whatever. You work in the emergency department and you have a woman, a 21-year-old woman, gravid one, para one, whose last menses was 11 days prior, presented to the emergency department with a chief complaint of the right lower quadrant abdominal pain, vomiting and vaginal spotting. The onset of pain was 1 day prior, and she noted it was worse with eating and moving.
Can we
Give a time? Okay, sure.
Yeah, give it time.
Oh, I don't know how to go back. I can see it.
Scroll back.
Yeah.
Scroll down.
Okay, yeah.
Yes.
Firstly, who knows what is gravid one, para one?
Could you please make one thank you very much. Vika was talking and I was not listening, so sorry. Sorry. We were both talking. I was talking as well.
Okay, gravid one means that she was pregnant once, and para one means that she gave birth once. So she had one pregnancy, and it results in giving a child, doing a childbirth, giving a birth. So she said her last menses is period basically, was 11 days prior. She came to ED herself, and she said that she has a chief complaint, which means mean complaint, like the ones that bother her the most, of right lower quadrant abdominal pain, which is right here, vomiting, and correct, and vaginal spotting. The onset of pain, which means the start of the pain, was 1 day prior, and she noted it was worse with eating and moving. Medical history. She has had chlamydia, flu treated 5 years earlier. She had preeclampsia with her first pregnancy, and she has no past surgical history. Moving forward, her status presence, which are basically which are basically vital signs. You can assess it if you want to, and this is important because you need to understand if she's stable or not. It determines your next actions. So I guess if you look at closely, she's pretty stable. She has everything within normal range. So she is up to the next examination. And you move to the physical examination, which is status localis. She has abdominal tenderness to palpation with voluntary guarding in her right lower quadrant, and tenderness to palpation in the right adnexa on pelvic examination. So I hope you remember everything, and I will ask you a question. It will be easy.
Maybe we will show
Sure.
on a person all this.
Yeah,
Volunteer.
Who will be my
women.
You will be my volunteer. Come here.
Okay, I can.
So she complains of the pain. This is her chief complaint. The only thing that bothers her. Also, she has vomiting, which is not quite comfortable, I would say, and she has vaginal. And she has vaginal spotting. So she complains of that. Vaginal spotting. It's blood. It's basically blood. Vaginal spotting is blood.
Yeah.
But she said that she had menses 11 days prior. So we assume that this is not menses.
Prior mean
Before. Yeah. And she said that her chief complaint is right here. And tenderness means that she's very, she feels it quite well, So when I touch it, she's like, oh no, it hurts so much, And, sure. This is the thing. So,
I'm interested too.
Okay, so moving forward, and she's stable. She has every vital sign within normal. So she's stable, you can assess her for
Right adnexa also mean
Right ovary.
right ovary,
So, right at the bench, I want you to give me 3 conditions that this patient might have in order of how dangerous they are. At least 3 conditions. It's common knowledge. It's not that hard.
Remember this.
Right? And her chief complaint is pain. She has vaginal spotting and she's vomiting. 3 conditions that this patient may have.
Appendicitis.
Correct. This can be appendicitis, right? Second,
Bleeding from ovary. I don't know.
bleeding from ovary.
Apoplexy.
Okay.
It's mean rupture of an ovary.
Ovary.
When the cell goes.
Okay.
How possible do you want the diagnosis to be?
No, it just defines your next action. questions. I want you to think what you are looking for when you what you assume this patient may have. It's not the end diagnosis, just what you're thinking of.
Yeah, of course. That's why I'm asking how possible do you want the diagnosis to be?
It's quite possible.
Quite possible, yeah.
Okay.
So we have appendicitis, we have rupture of ovary, we have ectopic pregnancy, something else maybe?
Also, she may be pregnant.
Cancer.
Yeah, cancer. It doesn't be cancer. It can be spontaneous abortion happening. She may be pregnant.
It can be endometriosis, guys.
Yeah,
We
but-
just said.
Obviously it is, but that's why we're not naming it.
Well, maybe it can be endometriosis. So, what are the laboratory testing that you want me to perform on this patient? What will you do in this case? Correct. What else?
Intravaginal ultrasound.
Transvaginal ultrasound. Correct. Yes. What else?
I think we were talking all the time.
Biochemistry.
All
Other people.
I mean, she's a normal patient. What would you prescribe to any patient that came to your emergency room? Like, what would you prescribe?
blood test.
Correct. You.
Can you tell out, please? I can't.
Yeah, you can. So Tanya already named that we can perform ultrasound, we can perform blood test. Also, I heard transvaginal ultrasound.
Yeah, and also you suggest at least two conditions that may involve pregnancy. So, of course, we need to ask this patient if she can be pregnant. Can she be pregnant or not? Maybe she has hysterectomy and you don't know. So, when asked, she said that she was not pregnant as she took levonorgestrel as an emergency contraception after intercourse once months prior. Do any of you know what emergency contraception is or what levonorgestrel does?
Plan B pill.
Plan B pill, yeah. I assume that many of you have sex, and I assume many of you may be familiar with this case.
Nice
We are medical students.
Yeah.
So medicine.
So, okay, I will give you some information.
only with our university.
Wow.
Translation.
Well,
It's going on.
okay, I will give you some information about how levonorgestrel works. And basically, levonorgestrel is a second generation.
Just speed
Slower.
slower.
You want to speak?
Yeah,
Slower,
because
okay.
I think
Okay, I'm sorry.
I'm full of energy.
Yeah,
I think
I am.
everybody is just drowning.
Yeah, if you have any questions, you can interrupt me and ask them if you didn't understand anything. So, levonorgestrel is a second generation drug. It's basically a synthetic drug for progesterone. It delays or prevents ovulation. It slows the egg migration due to impaired ciliary function, and it discourages fertilization by inhibiting sperm function and migration.
So.
Wait, I will show you. I will show it here. It's okay. It's okay. I will show it. Don't worry. Chill.
Okay.
So, we will rank it by days. So the first day is a day when oocyte is released into the embryo. Is released from ovary. So it's a day 0. We know that this drug inhibits ovulation. So it may not happen at all. So there's no chance of getting pregnant if egg is still inside the ovary. It's obvious. Do you, by chance, remember where fertilization occurs? I mean, there is an answer on the screen, but do you remember where does it happen? Like inside the uterus, inside the ovary, where? Yeah, correct.
Inside fallopian tube. Yeah.
Correct.
So basically, where is the?
In
Okay.
That's my gift to you. You can keep it.
Thank you very much.
It doesn't work anyway.
It's very dangerous. So basically, we started here.
Yeah.
You see that they're there. The sperm is there.
Yeah,
No,
right.
lower.
So we will say it like that. So the day 1 is the day when fertilization occurs. Well, how it can be prevented? First of all, sperm may not even come inside the uterus because this drug thickens the mucus inside of the cervix, so sperm can just like pass it. So there is no chance of fertilization again. It will. No,
Thickens means.
I'm sorry, but it will block out. Okay.
Thickens means that there is something very liquidy, and
Yeah.
sperm is usually very liquid.
No, it's not sperm. It's the mucus inside.
Oh, the
cervix.
mucus. Sorry, the mucus is liquidy, and when it thickens, it's just like a jello or something like
It
that.
basically can pass through the gate, I would say. Also, it slows migration of the egg, so there's less chance of meeting with the sperm because egg is quite far from the sperm. So yeah, no fertilization again. Also, by day 3 to 4, cell division occurs, and at the day 5, blastocyst inside of the uterus. And there were actually some trials discovering maybe this drug can affect endometrium, but no. There is no affection of the implantation in this case. So at the day 5, this drug is ineffective because the blastocyst is already inside of the uterus. There will be implantation. So this drug must be taken as soon as possible within 72 hours after intercourse. Moving forward. I will give you, oh, no, I will not. No. So maybe some of you have a clue why I gave you this detailed information about liver notostrel and our assumption what this patient might have. No, it's quite interesting. I will repeat to you.
Well, yeah, like a quick recap.
Yeah, I will repeat to you that it prevents ovulation, it slows the migration of the egg, it prevents fertilization by inhibiting sperm from coming there, and it also does not affect implantation.
Wait, isn't our patient 11 days post her last menstruation?
Yeah, but she may think that this was menses. Maybe it was like implantation of bleeding or whatever. It can be.
It's too early for the implantation of bleeding.
Yeah, I know, but maybe it was abnormal uterine bleeding. So we don't know. She said it was menses. So we don't know.
Oh, you mean the one that she okay.
She said it was menses, but we don't know if it was actual menses.
Yeah,
She may be confused. Yeah.
Yeah, she just saw
Blood. Yeah.
That's all. That's
So
all we can rely on.
do you have a clue what this may be? I mean, I assume this is not appendicitis.
What is the question? What is the question?
Do you understand the connection between liver notostrel and the condition that this patient had?
Okay.
She didn't.
Correct. Your lab results came back. Her chemistry panel unremarkable. Complete blood count unremarkable with hemoglobin within normal range.
Unremarkable means
okay.
Okay.
Yeah, everything's fine. Liver function panel unremarkable. Uterine pregnancy test positive. So she's pregnant. And yeah, it's two ways now. It's either ectopic pregnancy or it's normal pregnancy. And since she's complaining of the pain, maybe something isn't right. So it's either spontaneous abortion or ectopic pregnancy. Moving forward,
or anything else.
Oh,
yeah, or anything else.
Yeah, there are still some possibilities. Yeah, this can be hormone producing. Yeah, it can be.
Tumor, again,
Yeah.
polyps.
Correct, but if we're speaking from the most common ideas, it can be. It's supposed to be pregnancy. Ultrasound results came back, and if you have an excellent vision, you see that this is transvaginal ultrasound of case report patient, showing a right adnexal mass adjacent to the right ovary, diagnosed as ectopic pregnancy. So this woman has ectopic pregnancy. This is what we stated based on ultrasound and based on our tests. So this is another one, and there is a free fluid in the pelvic cul-de-sac. Cul-de-sac is a pouch of Douglas or
Cavity.
Yeah, it's cavity basically. And free fluid, what does it mean? What can it be? Free fluid?
Bleeding.
Yeah.
Okay, I'm leaving. I'm sorry.
No, it's okay. It's okay.
No, I have to go. I'm sorry. You're so cool.
Thank you for coming.
Bye. So my main question: why ectopic pregnancy is so dangerous? What is the main complication?
In the blood.
Blooding?
Hemorrhagic shock.
Why? Why?
Because bleeding is very severe.
Where comes the bleeding from? Where does the bleeding come from?
Rupture of ovary.
Correct. Since it's not the place to grow a baby or embryo or whatever, it can rupture very easily. And this pregnancy always has to be terminated. There's no chance of childbirth in this case. It just increases the possibility of the woman dying.
No way that your baby
yeah.
will grow in the fallopian tube, like.
Yeah, baby is quite huge and fallopian tube is quite small. So she has a free fluid, but her hemoglobin is in normal range. So we assume maybe this is blood, maybe we don't know. But she's stable for now. She has her vital signs normal, and she has okay level of hemoglobin. So we have two options for treatment. Do you happen to remember the options for treatment of ectopic pregnancy?
Surgical.
Yeah, correct. One is surgical and another one? Who had gynecology? Who can I ask specifically? No one? Okay. If you don't know, I will give you an answer. Another option is methotrexate, which is basically a drug that stops growth of the cells. It inhibits nucleotide production, and it stops growth of early ectopic pregnancy without the need for surgery. Avoiding surgery is quite well because you will have to keep your tube. It's better than losing it. Like it can result in infertility, which is not many people want. It can help remove remaining fetal tissue after surgery during ectopic pregnancy. There are always some risk and potential complications and alternatives. If you want to read it, I will give you a time. I won't be reading it. If you want to picture it, like, go on.
No one.
Okay, it's not interesting. I understand. Okay.
But it's the thing that you should remember, because when Marina discussed this case with me, I also didn't remember methotrexate is also the option, and I passed gynecology and I had an extra course. Yeah, so this is really important to understand that not only surgery, yeah, there is an option. Sometimes methotrexate is an option.
I have to remind you that watch and wait approach is never an option in this case because it will obviously result in very dangerous complications. It may watch and wait. It's when you watch and wait. It's when you schedule the follow-up for the patient and like see the condition. So in this case, they decided to give methotrexate, which is like because the pregnancy was in early stage, and they decided to schedule a follow-up. So follow-up 4 days after the diagnosis. The patient developed a shortness of breath and substernal pleuritic chest pain during her follow-up visit. Do you know what this may be? This is very, very dangerous complication. I mean, it's not like this patient doesn't have it, but just in general, what this may be. Pulmonary embolism, have you ever heard of it? TELA, from invalidovich artery. So they got very scared. They provided CT scan on this woman, and yeah, everything was fine. It was just like probably panic attack, I don't know. So her laboratory values were as follows: chemistry panel unremarkable, white blood cell count 6.3, hemoglobin is 11, I would say milliliters per liter. So it kind of dropped since we last saw her. So there is some kind of hemorrhage happening. Her hormone level have gotten higher, which is not a good sign because methotrexate is supposed to stop the pregnancy, and it's getting higher. So maybe it didn't work. But they decided to schedule a follow-up and give her another dosage of methotrexate. So 8 days after that, the patient was seen. Her hormone level dropped significantly, and they said it was okay. And 11 days after, she came back again with the complaints of vaginal bleeding for 1 day, increasing right lower quadrant pain, as well as lightheadedness. Lightheadedness, do you know what lightheadedness may mean?
Dizziness.
Yeah, but like in this patient, why lightheadedness is not okay sign? Like, why is it bad? Do you understand? Do you understand? No, you don't. I mean, yeah, lightheadedness, why is it not okay? I see you
Do you understand?
No, holy sleep. I want you to shake your brain a little bit. Lightheadedness, why it's not okay?
It's always not okay.
I mean, yeah, but why? She may be losing blood. It may be early sign of hemorrhage happening. Yeah, and I give you results. I mean, she's.
But blood pressure is okay. That's
yeah,
why we.
Yeah, she's still pretty stable, but this may mean that she has hemorrhage. Her physical examination was remarkable for diffuse abdominal tenderness, and diffuse abdominal tenderness is actually not a sign of like bleeding. It may be bleeding, especially in the right lower quadrant with rebound tenderness. She had severe cervical emulsion tenderness and blood in her vaginal vault on pelvic examination. Also, you can see hemoglobin is okay. Better human chorionic damage is still dropping, yeah. So methotrexate is working, but she was scheduled for ultrasound, and it revealed internal development of moderate amount of blood products in the pelvic cul-de-sac. So she has hemorrhage, and this is obvious reason to take her to the surgery. She has hemorrhage, so she possibly has a rupture. So she was taken emergently to the operating room by service, and intraoperative findings resulted in 200 milliliters of blood in the cul-de-sac. She required a right self-appendectomy and removal of the right adnexal ectopic pregnancy. She recovered well, and after a remarkable post-operative course, was discharged this is a uterus, and this is an ectopic pregnancy, which is quite huge, as you may see. It's quite big. Also, this is a gross pathology, so this is removed. And this is another case of ectopic pregnancy with hemorrhaging happening inside. And this is a cut ectopic pregnancy. So, discussion. Do you have any questions about this?
Yeah, I have a question because when we had obstetrics, our tutor told us that we never use any like methotrexate or the others because methotrexate is usually used for the plastic disease. And why can we just do the surgery for the first time because we see the blood?
Because the surgery will result in impaired fertilization. You always want to keep fertilization function inside the womb because maybe she will have another ectopic pregnancy and it also results in surgery, which leaves her with infertility for sure.
But doesn't methotrexate has its own side effects?
Yeah, sure.
Isn't it as severe as surgery probably? Can we compare them?
I mean, it's in the guidelines. Methotrexate is part of the guidelines. It's not what I think is supposed to be here. It's the part of the guidelines. Also, you want to keep as much organs as you can because if you remove them, well, you can also remove everything else. You want to keep as much as you can because fertilization is very important for many women. Like fertilization function is very important, especially in gynecology. So this is why.
But I think, I don't know, maybe it's not, but we told sometimes that we can do органосохраняющую операцию to save the fallopian tube. And we see the vaginal bleeding and we see the blood in the pelvis. And why can we do органосохраняющую операцию and do not use methotrexate?
I mean, this is a decision of these doctors. Maybe I don't know why they did it. Maybe they said that this was the best option. They would try to manage it because it was very early pregnancy. And they decided that every surgery has its own complications, as you may know. It may result in very severe sepsis, for example. So it always, as in my opinion, and I guess in the opinion of the doctor, to try some non-surgical treatment first. Because methotrexate is very commonly used for ectopic pregnancy. It's in the guidelines.
In Russia or
I don't know, I haven't read Russian guidelines.
I mean, in this case
This is not Russia. This is, I guess it's USA, as far as I remember. So this is what I have. I don't know why they decided to do it. They actually explained it. They tried to justify their actions. They said that in this case, they decided to wait and watch with methotrexate dosage given, administered. So this is, yeah, I guess it's one of the options.
we will never know.
Yeah, I guess
Answers will never know.
yeah, we will never know. Probably Russian they wouldn't tell us about this case. As you, yeah, it's not my thing. Also, I would like to point that levonorgestrel is not medical abortion; it's contraception. Medical abortion is termination of the existing pregnancy. In levonorgestrel, even if it's taken after intercourse, it prevents pregnancy. So it's very different. It's important to understand. Even if some of you are religious, if it's important to you not to kill the baby or what you feel is right, it's important. But this is not medical abortion. It's prevention of the pregnancy, contraception. It's not abortion.
So in that case, basically, she took levonorgestrel to,
Prevent pregnancy.
but she already had been pregnant.
Because levonorgestrel slows the egg maturation, the fertilization may happen still, and just since it's slowed, it can reach uterus, so it implants where it stays.
I mean, so how come she didn't achieve the results she wanted?
I mean, it's not 100% contraception.
She
did it in on time.
Yeah, she did.
Yeah, she did on time, but it
Didn't work.
didn't work. And sometimes, yeah, it's very important to understand it's not working like
yeah,
every time.
contraception is 100% unfortunately. And if you have a patient, if you work in gynecology field, and she said that she had plan B contraception, always keep in mind ectopic pregnancy as a complication of this case. It's very important, and it's not very common. So maybe a lot of women use plan B contraception, but not everyone will tell you, and you still need to ask this question. And once again, if you have a patient and she is female and she has she's very young or she has her ex-life or whatever, it's important to consider ectopic pregnancy because it's very, very dangerous. It can result like in rupture and whatever.
Remember Dr. Howard's patients always lie, so
Yeah,
don't you ever exclude ectopic pregnancy if the patient says, "Oh no, I'm a Mary Virgin."
Yeah. So, and based on ectopic pregnancy, there are some like common places where it can happen. Just like for your basic knowledge, it can happen in fimbrial, it can be ovarian, but most commonly is ambulary, like which is patient have. It can be isthmic, it can be intestinal, it can be where cesarean scan is, and it can be intramural, which is very, very rare.
And you need to remove
the whole unfortunately it's hysterectomy.
the whole uterus.
And it can be cervical. So there are many options, and it's important to consider because I will repeat once again, there is no chance of childbirth in case of ectopic pregnancy. Also, it can be, by the way, it can be abdominal pregnancy, and I saw a very cute case of, I forgot it. I don't remember the word, but it's, I just had it. Suddenly berryenness. It's very rare complication. Yeah, but it still can happen. So, once again, emergency contraception is not medical abortion, and you need to explain it to the patient if they are religious ones. So, yeah. Thank you very much for your attention.
Marina. Do you want to play a game? I understand if you want, because it's like very, very late and you stay here for a long time. But we have opportunity to play just a little 10 minutes game. Kahoot. You want to play Kahoot? Okay. If someone needs to go, no one be offended by you leaving. You won't.
I won't know. I won't.
You won't. Okay. So. Хорошо. Одну секундочку тогда. Можно поболтать, можно задать вопросы, можно походить чуть-чуть.
Спасибо большое.
Пожалуйста. Так. You're welcome. Да, я поняла.
Они подумали, что у нее снизится гонопривит периодически. Ну, наверное, связано с тем, что интернет работает, мы пробуем дать еще, а тут наблюдаем. Но они не успели, потому что не сегодня помещение.
Вообще, как мы можем работать? То есть, вот эта имплантация произошла, потом... Да, и он больше не называется.
Да, называется центральный рельс, но просто изируется.
Там просто
Oh yeah! Ура! So Google Kahoot in your any kind of website you use, or you can download the app and also. Why? What is going on? No. No money for you. Continue for free. So. So, Все скачали Kahoot?
Может, прямо посередине вы подвинем, давай я тебе помогу.
Куда?
Вот эту штуку, ну типа телек.
Скачивайте Kahoot, и там, где написано Enter the pin, вводите вот этот пин. Всем нормально видно?
Ой, можно?
Придумывайте имя себе и будете... Game pin 7521183, and you need to write down your name or maybe username or whatever. Maybe number. Waiting for players. No one joined us yet. Why are you not? It's not like a play that when I like 5 mark for you, 3 mark for you. No, it's just a game. Don't be afraid. It's okay to not to know. And there are questions are very simple, like very simple. There is a Wi-Fi now. Oh, you can try with my Kahoot. It's okay. So everybody in?
Пожалуйста, те, кто не зашел, скажите мне, почему вы. Заходите, пожалуйста. Что?
Скачивается? Это
Нет, вот сейчас зашло, но я не знаю, как сначала
Нет, enter the pin. Enter pin.